Welcome back to the Clinical Anatomy Podcast. I'm Dr. Khan, and I am absolutely buzzing today because we're diving into the body's ultimate electrical grid. We're talking the big divide, central versus peripheral nervous systems. If you want to understand how a patient goes from feeling a pinprick on their toe to jumping away in pain, you have to know these boundaries.
And I'm Dr. Sara. While Dr. Khan brings the energy, I'm here to make sure we keep the definitions precise for your board exams. Anatomically, the distinction is clear-cut. The central nervous system, or CNS, is just the brain and the spinal cord. Everything else, the cranial nerves, the spinal nerves, and those little relay stations called ganglia, that is the peripheral nervous system, or PNS.
I love that. I always tell my students to think of the CNS as the command center sitting in a high-security bunker. It's protected by bone, the skull, and the vertebral column, and wrapped in those three layers of meninges, the dura, arachnoid, and pia mater. It's the mainframe computer. But Sarah, a computer is useless if it's not plugged into the rest of the world, right?
Exactly. The PNS is your wiring. It's the fiber optic network that carries information back and forth. Now for the boards, you must remember the numbering. We have 12 pairs of cranial nerves emerging from the brain and 31 pairs of spinal nerves leaving the cord. Dr. Khan, why does this structural split matter when a patient actually walks into the ER?
Why does it matter clinically? Because the bunker is a tight space. If you have swelling in the CNS, there's nowhere for that tissue to go. But in the PNS, things are a bit more spread out. Think about our 65-year-old patient from the text. He's got crushing chest pain radiating down his left arm. That's a classic myocardial infarction. Now, the heart is internal, but the pain is felt in the arm. Why? Because the sensory wires from the heart and the sensory wires from the arm are both plugging into the same part of the mainframe at the spinal cord level. The brain gets the signals crossed.
That's referred pain, and it's a high-yield concept. To understand it, you have to master the spinal nerve structure. Each spinal nerve starts as rootlets that join into two roots. The posterior root is sensory. It has that characteristic bulge, the posterior root ganglion. The anterior root is motor. When those two join, you get the spinal nerve, which is a mixed nerve containing both sensory and motor fibers.
This is where students get tripped up. They hear roots and Rami and their eyes glaze over. Think of the roots like the specialized entrances to a highway, one way only. The posterior root is the entrance only for sensory data coming in. The anterior root is the exit only for motor commands going out. But once they merge into the spinal nerve and then split into Rami, it's a two-way street. Both directions of traffic are moving in the same cable.
High-yield alert. If a patient has a lesion in the posterior root, they lose sensation but keep motor function. But if they have a lesion in the anterior ramus, they lose both. That distinction is a favorite for examiners. And while we are on the topic of sensory distribution, we have to mention dermatomes. A dermatome is an area of skin supplied by a single spinal nerve. If a patient has a sensory deficit at the level of the nipple, you should immediately think T4.
T4 at the teat, T10 at the belly button. That's how I remember it. But let's shift gears to the autonomic nervous system, the ANS. This is the autopilot part of the PNS. It's subdivided into sympathetic and parasympathetic. Sarah, give us the board prep breakdown of the outflow.
The sympathetic division is thoracolumbar. The cell bodies are in the lateral gray horn from T1 to L2. These are your fight or flight nerves. The parasympathetic division is craniosacral. It comes from cranial nerves 3, 7, 9, and 10, plus the S2 to S4 spinal levels. These are for rest and digest.
Clinically, this is huge. When our MI patient is in shock, his sympathetic system is redlining. He's pale because his vessels are constricting, and he has goose flash because those tiny erector pili muscles are contracting. The body is trying to save itself. You know, I strive to be every student's doctor of choice for clinical pearls, and here is a big one. The ANS is a two-neuron pathway. There's a synapse and a ganglion before the signal hits the target. The somatic system, the one that moves your biceps, is a direct one-neuron shot.
That two-neuron versus one-neuron rule is a cornerstone of neuroanatomy questions. Also, remember that while the CNS uses nuclei for clusters of cell bodies, the PNS uses ganglia. If you see the word ganglion on an exam, you are looking at the peripheral nervous system by definition.
And don't forget the white versus gray matter. In the CNS, the white matter is the insulated axons, the insulated wiring. The gray matter is the cell bodies, the processing chips. In the spinal cord, the gray matter is that butterfly shape in the center. If you lose that gray matter to a disease like polio, the motor neurons are gone and the muscle becomes flaccid.
We've covered a lot of ground, from the bunker of the CNS protected by the meninges to the wiring of the PNS with its roots and Rami, and the functional split of the autonomic system. It's all about the flow of information.
Absolutely. To wrap up the most important takeaway, the CNS is the brain and cord, the decision maker, while the PNS is the vast network of 31 pairs of spinal nerves and 12 pairs of cranial nerves that execute those decisions and provide the sensory feedback. Understanding where those wires cross and how they're bundled into roots versus rami is the key to localizing any neurological injury.
And for your exams, always distinguish between roots, which are functional, sensory, or motor, and rami, which are mixed. Master your dermatomes and you'll be ahead of the curve. See you in the next session.